Good evening and welcome to our 39th season of Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth, on the Duluth campus, and a family medicine physician at Gateway in Moose Lake. I'm your host for our season premiere, a COVID-19 update. For your information, this season we will be rotating hosts from the medical school. Remember that the success of this program is very, very dependent on you, the viewer. So please call in with your questions tonight, or you can send them in also to our email address, askask@wdse.org. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Amanda Nasca, infectious disease specialist with Essentia Health, and Dr. Harmony Tyner, infectious disease specialist with St. Luke's Infectious Disease Associates. Our medical students answering the phones tonight are Zachary Buchholz from Spring Valley, Minnesota, Lauren Ross from Moose Lake, Minnesota, and Benjamin Wills from Niagara, Wisconsin. And now on to our program, a COVID-19 update and our 39th season of Doctors on Call. Dr. Harmony Tyner, now I'm mixing up names here, this is bad. Dr. Tyner, welcome to our program tonight. It's very nice to have you. You want to tell us just a little bit about your practice? And I understand that you and St. Luke's are doing some work nationally too.
We are, yes. Thank you so much for having me again. I am Dr. Harmony Tyner. You can call me Harmony or Dr. Tyner, either one. I work at St. Luke's as an infectious disease doctor. I work both inpatient and outpatient, which means I see patients in the hospital with infections and patients as outpatients with infections. That includes everything from COVID to HIV, parasites, bacteria, fungi, etc., across the board. I love my job. In regards to your question about the study that we're doing nationally, we're working with the CDC and a research company called APT as one of 6 sites that is doing a study to evaluate the epidemiology of COVID. What does that mean? It means there's a lot of really big questions we're trying to answer, like, can you get COVID twice? We don't know. If you've had it before, can you get it again? Does having antibodies against COVID protect you from getting it again in the future? Again, we don't know. Who gets COVID and how many infections are subclinical, meaning don't have any symptoms at all, versus have symptoms, and what puts you at risk for having a more severe infection? So these are the questions we're trying to answer at St. Luke's right now. It's been a busy time, but it's also really interesting.
Great. Dr. Nasca, welcome. Great to see
Thank
you again.
Likewise.
It's been a long time.
Yes.
Welcome. You want to tell us a little bit about yourself?
Yeah, so I'm Amanda Noska. I'm an infectious disease physician at Essentia Health. Like Dr. Tyner, I see inpatients and outpatients for a variety of different illnesses, including COVID, which is why we're here. I also see folks living with HIV, as she mentioned, and I have an interest in treating hepatitis C as well. That's sort of one of my niche areas within infectious diseases. One thing that we have been trying to work on at Essentia is looking kind of at the different treatment modalities and defining the kind of best approach that we can, refining the treatment of COVID and kind of honing in on that and figuring out how our patients do. And we have been organized a treatment discussion group every was every Thursday, now it's once a month, to kind of hone in on what the literature is saying and what treatments we should be using and phasing out as this pandemic rolls around and moves on. So that has been a very satisfying part of my job lately, and that's something that I'm proud to be working on at Essentia.
Well, we'll come back probably and talk about some of these things again a little bit. Dr. Tyner, what is COVID?
What is COVID? COVID's a virus. Specifically, it's something called a coronavirus. I don't know if this is what we're talking about, these handouts or not, but one of the medical student groups made a nice handout that talks very nicely about what the coronavirus is.
It's not up
There it
here,
is.
it's up over there.
Viruses are itty bitty, teeny tiny microscopic little particles that technically aren't even alive. They require a living host, living cells, in order to propagate or multiply themselves. That's why people are so important to the viruses. It's a virus, and as a virus, it doesn't respond to things that kill bacteria. Bacteria and viruses are two totally different things. If you think about them in terms of size, a marble would be as a beach ball would be to a bacteria. A virus would be the size of a marble compared to like a beach ball in roughly terms of size. They're very different, and the treatments we have for bacteria don't work against viruses. So this is a virus. It's a respiratory infection that is transmitted through tiny drops of saliva and snot, basically.
Yes. Amanda, what is a pandemic?
Ooh.
Right, that's a great question. So pandemics have happened throughout history only, I would think, 5 times. This would be our 5th. And a pandemic happens when a global population is infected to a degree that is quite devastating to the population. The 1918 pandemic, I may get the numbers a little bit wrong, but there were massive amounts of deaths, 675,000 deaths within the US from the 1918 pandemic. And that influenza virus was not a really devastating virus for young individuals, 20 to 40 years of age. So the pandemic has to be global, and it affects a massive amount of population, and many of the pandemics have had very high mortality or deaths associated with them.
So I know that both of your facilities are working on what is the best treatment.
Yeah.
So let's go back. When this first started out, we had no idea. I hope that the listeners understand that this was entirely new for medicine. We had no textbooks to go to, nowhere else. So kind of take us from there, and you can take turns doing this or however you'd like. How did we get from that point, and where are we today?
Yeah.
Sometimes it feels like we haven't come very far, but we do have better ideas now.
Yeah.
When we first started out, we knew it was a respiratory infection, and so the primary thing we did was try to support people's breathing. And that's still one of the major ways that we treat this infection, is to support their breathing, make their breathing easier. Preventing it is the biggest thing. But at the beginning, we tried using medicines that they had attempted to use basically across the world. In the places where they had this infection first, they tried all kinds of different things, and some things seemed to work better than others. And as they were just trying things out, people in the infectious disease world and in medicine in general were listening very carefully to what seemed like it worked, and they'd grab onto anything that seemed like it might make a difference. At the beginning, it seemed like hydroxychloroquine and maybe azithromycin and possibly even a medication called Kaletra, all these other names that have kind of come and gone that no longer seem to be effective. In fact, the risk seems worse than the potential for benefit. So we don't use those medicines anymore. At the same time, other medicines were becoming available, and I'm sure Dr. Nasca is much
Well, we'll let her bring us up
okay.
to that, because she's working on that.
Yeah.
She led us into this a little bit earlier.
Yeah.
So.
Yeah, well, so I totally agree with Dr. Tyner, though. Of course with you, Dr. Christensen. It's humbling. Medicine can be very humbling, because we are in a place where we don't have textbooks, we didn't have the clinical experience. So we have gained that, and I'm actually quite impressed with, it can be discouraging, but I'm also very impressed with the progress that we've made as a world, globally, in such a very short period of time under extreme pressure. So yes, while hydroxychloroquine and Kaletra and many others have phased out, remdesivir is a novel antiviral that does show, the studies have some weaknesses, but they do show some hope that they shut down viral replication and might stave off worsening disease further down the line. Remdesivir is best when given within the first 7 days of symptom onset, and it is most effective in that situation. So it's important for folks who might feel sick enough to be hospitalized or to, very, very ill, to try and seek care early if they're very sick, because it's something that we can triage and look at and potentially prevent people from getting sicker. So remdesivir is an antiviral, and that has shown to be very effective at reducing the clinical progression of disease in some folks. Another thing that's been studied, at first we thought steroids were very dangerous because they do increase viral replication. But at the same time, they've studied dexamethasone, which is a steroid that was used with the most severely ill. And that actually shows, has proven to have some benefit, especially in very ill people who are hospitalized with severe COVID, which is kind of a technical classification, or somebody who's sick enough to be on a ventilator. And then lastly, we have been part of the expanded access treatment program through Mayo Clinic with convalescent plasma. That is now closed after a kind of critical review by the FDA and the transition from the Mayo Clinic studies to this expanded use. But the studies are pretty mixed there. We do know that giving plasma early, within the first 3 days of diagnosis, seems to have some benefit, and we think we know that. And I hesitate to say that with any confidence because the studies are fairly weak. Maybe Dr. Tyner has something to say about that. But also, there's been 2 randomized controlled trials of convalescent plasma that haven't proven to be wildly successful. So we do offer that because we still need more tools in our toolbox to treat that. I'm really encouraged by, there's an anti-T cell therapy that they're developing. There's plenty of vaccine trials, which I'm sure we'll get into down the line, that are being actively pursued. And there's a monoclonal antibody that has been explored and is very, very exciting. And then we have these brilliant scientists who have been looking at using all the different medications that we already have and seeing if we can repurpose them, find a different use for them. And it's a really interesting thing because they start with bench science and then roll that out. Some things have worked out and some things have not, but certainly remdesivir they used with MERS, and it has been transitioned over to COVID, and I'm grateful we have that antiviral available to people to treat.
Yeah, there's been a lot of changes, and I've been impressed with the way Minnesota has worked together with the mHealth, Bethesda, Mayo Clinic, and the facilities here as we've worked on this problem. Dr. Tyner, this is a virus, and we think it's you. I think it was you that brought up how it might be spread. Yes. How can I avoid getting it? Because we need to ride this out, I think, until we get some type of a vaccination. And is the pandemic going to hit us, and what's going to happen here?
There's a couple of questions there.
I know, I've mixed them together because I figured you'd both get in there.
Oh my goodness. Is the pandemic going to hit us? I think at the beginning we were hoping that we saw this peak and it was going to go away, but there's always this danger of maybe in the future it was going to come back and it might even be worse than ever. Not to be a fearmonger, I don't want to be that person, but I do think it's worthwhile saying that I don't think we've seen the end of it. In fact, I think what we see this winter may be as bad or possibly quite likely even worse than what we saw last spring, which isn't to make anybody afraid or to kind of bring up panic, but it is to say, hey, we need to be just as careful as we have been. One thing I want to acknowledge kind of going into that warning is that this has gone on a lot longer than many of us ever feared it could have. We feared it might, but I know that a lot of people are becoming isolated and sad and lonely and depressed and all those things that happen when you're trying to be safe. I acknowledge that, and I do encourage people to reach out and maintain those close relationships as much as they can. That said, gathering together in groups is one of the ways in Minnesota that we've found that it's been traveling and spreading the greatest. So things like funerals and weddings have been a problem. So staying to yourself as much as possible, interacting with people largely who are in your own home, although that's not always possible to do, washing your hands, wearing a mask, specifically a cloth face covering when you're out in public, and cleaning frequently used surfaces. And again, remembering this is transmitted from person to person, and thereby decreasing the number of people you interact with is probably the most important thing you can do. even though it's not always possible to decrease everybody as much as possible.
We just put up again the COVID-19 answers for kids. And at my age, it's good answers for me too. I think it's way beyond just the kids. But there's some really good information about what COVID is like, how it's spread, and what you might or might not be able to do to avoid COVID. So I really encourage you to look at this. It was put together by people from the University of Minnesota Medical School, Duluth, on our campus. And you can pull this up. It's free for you to use and to look at. The email address is z.umn.edu/youth resources. So please feel free to look at that. I think it's very helpful. Our people have done a very nice job at condensing this. There's a lot going on at the present time. I know that there's concern about fomites, silverware, things that we touch, tables and so on. Is it necessary for us to keep scrubbing everything like we are? Does it really last that long, or is it just air spread, aerosol spread?
Yeah.
And I think it's your turn.
Sure. I did also want to add that, we can still spend time with one another. We, for example, are 6 feet apart. Yep. We're indoors technically, but, it's still okay to be a human being and social, and we need that. We're not going to get through this without one another. We just have to be safe about it. So trying to keep your distance and wear masks, as Dr. Tyner mentioned. So as far as the spread, I think there's a lot of confusion about that, and I think it's important to acknowledge that, because as scientists, we need to be vigorous in looking into those possibilities. I think the reality is it is both. It's spread through something we call droplets, which means, as Dr. Tyner mentioned, little particles of virus that are contained in spit and secretions. And then it's also spread in the air. And that kind of depends upon what you're doing. So if I'm speaking very loudly, for example, I'm more likely to exhale forcefully particles than if I'm whispering. And if you're coughing or sneezing or singing, for example, those are actually more likely to cause little tiny particles to be in the air for longer. Droplet kind of transmission, or these larger particles that we can sneeze or exhale, those tend to stick around within a meter of a person. And we think that that's largely the way that COVID is spread, when you're not singing, coughing loudly, or sneezing, stuff like that. So the 1 meter issue is that you can exhale these tiny little particles, and they can hang out in the air, but they tend to be heavier than the ones that might be drifting for a longer period of time. And when you exhale those particles, if they're big, they'll drop to the ground within a meter of you. That tends to be a problem for surfaces, for example, because the virus can live on a surface. It depends upon which surface it is. If it's stainless steel, it's a couple days. If it's plastic, it can be up to 3 days. If sunlight hits it, then maybe it's not going to live very long at all, maybe 20 minutes. It depends upon...
So I'm going to pull you back a little bit. So are masks helpful?
Yes. Masks aren't perfect, and I think everybody knows that, which is perhaps part of the confusion. But masks, they're not perfect, but they're very helpful to prevent you from exhaling or sneezing or releasing those viral particles into the air in your immediate vicinity. They're also helpful in terms of filtering, and different masks filter better than others. So a cloth mask, for example, certainly doesn't filter quite as well as a procedural mask or an N95 mask. But they are helpful, and there's pretty good data on that. They're definitely not perfect, but they're what we have.
So a bunch of questions, and I'm going to go for short answers now. Is it safe for a person to go into a clinic for something non-COVID related, or should someone wait until the surge is passed before they go in?
You need to go to your doctor for things that need attention. Don't wait. I think one of the biggest things we're seeing that's frightening is that people have postponed necessary care, and we're seeing people become sick and die in some cases because they've postponed things that really needed attention. So I would say the answer is to go see your doctor, and if you're not sure if you need to be in person or not, call ahead, and they can help you decide if you can do it by phone or by video call, or if you should go in person. But don't postpone.
Yep, and I think everybody's got a system of looking at it. There was an article in the Duluth News, and the question has come up a couple of times: does COVID survive in Lake Superior water or in a lake? And from what I read at that time, because we talked about this before, and I know that you're both, from what I read, it does not. But that's all I know about that one. If you test positive for COVID but experience no symptoms, how long do you need to isolate?
So if you test positive for it but no symptoms, the CDC is very clear about that. It's 10 days.
Okay. Harmony, are the COVID death numbers inflated, as many claim? And then the other part of this question is, do hospitals get reimbursed more money if the death is due to COVID?
I don't know the answer to the reimbursement question.
I don't either.
But I will say that there's been rumors that people who have passed away who happened to have COVID at the same time were attributed to a death to COVID. I'm not aware of that being the case. I know of the patients who've passed away in our hospital from COVID have been assigned a death due to COVID. If they've passed away from a heart attack, it's due to a heart attack, and they happen to have COVID. It's not being inflated in our hospital. I can only speak to that.
A caller says, go outside in the cold and look at your breath and see how the moisture spreads. That's a really good
advice.
Trick.
Thank you, caller.
That's right. Seasonal flu shots. What are you thinking?
Get them.
That was quick.
Absolutely. Don't wait.
For it. Yep. It's a good plan.
Are ultraviolet wands any good for cleaning to prevent against COVID?
I don't know that that's been specifically studied for home use. Certainly UV light does kill COVID. And we have some data to suggest that that is the case.
I've tested positive for COVID in the past. Can I get it again? And if you can both jump into this, what about mutations too?
The answer is we don't know.
Okay.
That's one of the things the study is trying to answer is, can you get it a second time? It may have something to do with antibodies, it may not. And we don't know if you can. And the mutation question.
Yeah, I think actually I agree with you. We don't know so much about that. We definitely have seen now what seemed to be 2 cases of reinfection. One was a traveler that had gone from Hong Kong to Spain, and another was a gentleman in Nevada. So that question remains to be seen, but I think the answer is yes, maybe. And the mutation question, it's a D614G. It's a new mutation that seems to be more contagious but less morbid. People do still get very sick from COVID, obviously, but it is a different virus than was present in Hong Kong.
Harmony, when's this pandemic going to end?
I wish I knew. I really, really wish I knew the answer to that. I don't think we know. I don't think anyone knows. Can't end soon enough, though. I'm sick of it.
Amanda, you're taking a trip. You're going to London. What kind of protections are you going to take for your airline travel?
Right. Well, first of all, there was a publication last week about airline transmission of this virus. So I would probably reconsider my flight. If I absolutely had to go to London, I would reconsider my flight again. But the transcontinental flights are the most dangerous. I would definitely wear an N95 mask. I would be careful not to touch my face and to keep my distance from other people as much as I could, and to try to find a flight where people weren't sitting immediately next to me, but in 2 seats away. And I would be very careful also to try to limit my use of the shared plane facilities, for example, the bathroom.
Oh, that might be hard, especially for an old man. Harmony, what's your thoughts?
I would also add to that, I agree with that, but I would also be aware of your destination. Some destinations require that you quarantine for 2 weeks when you get there, and that can be a nasty surprise if you didn't know it in advance.
There are planes that are going out and back so that you can get your airline travel in. I suspect the same thing would be in the bus or a train. It's shorter period of time, but
Yeah,
The
that's
density
so
of
critical.
people. The density of people is really what the problem is.
And the shorter period of time is pretty critical. You know, international flights are different than flying from Minnesota to Chicago.
We
for
consider
example.
close contact to be within 6 feet for 15 minutes or longer. So kind of keeping that rule of thumb.
we're running down on time. There's the other piece that we did not talk about, and that's the future sequelae of this disease, of which we really do not know. And with only 30 seconds, I'm not going to go into it, but it's something that I think everybody should keep their eyes on because we are seeing some changes and differences. I want to thank our panelists, Dr. Amanda Noska and Dr. Harmony Tyner, and our medical student volunteers, Zachary Buckholtz, Lauren Ross, and Benjamin Wills. Please join Dr. Paula Termulin next week for a program on breast cancer and survivorship, when our panelists will be Dr. Stephen Bonin, Dr. Verna Thornton. Thank you very much for watching tonight. It's been a great program. Welcome to our 39th year.